Smith. I am an NHS GP in Suffolk. I have 7,000 patients, and I'm very much a real GP. So I see every age group, men, women, babies, you know, you can imagine everything, but women's health is definitely my area of expertise. And so within my surgery, I see all the women for their contraception, their coils, their implants, their menopause care, their hormones, everything. And I'm also co-founder of the Well HQ. So together with Baz and Emma, we created the Well HQ about 5 years ago now, and we co-authored the Female Body Bible, which is our book. And I'm gonna talk to you tonight about the menopause. This is something that I talk about all the time. I mean, if you could see me in my surgery, even today, like I had about 10 different women coming in wanting to talk about different aspects of the menopause. So this is very much something I do all the time. It's very difficult now, I think, because there's so many people know so much now, which is really good. So I always think it's difficult to gauge how much or how little you know, because some of you may even be going through it yourselves, or maybe on HRT and may know a lot about it. So, you know, if you feel that you know it, or, you know, I hope that this is, and that you may learn something from today. So what I will do, I tend to try and sort of answer a few of what I expect questions during the talk. And then at the end, there's going to be loads of time for questions. So please do anything that you think you'd like to ask me, please just, we can go through it, no bother. So I'm now going to go, hopefully that you can see, yay, it's working. Okay, so let's start off with what is the menopause? Okay, so it is an inevitable female life stage. So this is something that every single woman will go through at some point in their life. And most women go through what we call a natural menopause, but some women will go through a surgical menopause or a medical menopause. So the medical menopause is like, say, for example, like my mum, who was put on medication after she had breast cancer to shut down her ovaries. That is a medical menopause. And a surgical menopause is when you have your ovaries surgically removed. Like, say, for example, Angelina Jolie is very famous for that. The menopause is, so when I say the natural menopause, so your ovaries very gradually stop ovulating. So if you imagine the previous talks that you've had, perhaps with Emma, and she talked about the incredible menstrual cycle and the ebb and flow and the rhythm of our hormones through our fertile years, the perimenopause is when that rhythm starts to get offbeat. And it's not every month, it's every few months or every 6 months, and you don't ovulate. And you, instead of getting this sort of ebb and flow of predictable hormones, you get this complete chaos and you get an imbalance of hormones, and this creates lots of symptoms. It's also very unpredictable, and so it can be really disruptive. And also, if you think about your ovaries that are sort of slowly stopping from ovulating, in some women it will happen very quickly, and in some women it can take a decade. So the perimenopause can go on and on and on in some women. And so it is what we call the hormonal roller coaster. And then once you're through the menopause, so the actual sort of definition of being through it is when you haven't had a period for a year over 50, or for 2 years between 45 and 50. And then you should never bleed again. Once you've stopped your periods, that should be it. And what's really a really important thing to highlight is that every single woman's experience is unique. Just like puberty, breastfeeding, pregnancy, our periods, our menstrual cycle, the menopause is exactly the same. Some women have some symptoms, some women have other symptoms, and it is very, very varied. And that is why the approach, the medication, the management approach is also very, very varied. Many women now will benefit from HRT, hormone replacement therapy, which I will go into in a lot more detail, and I can answer as many questions, because this is often the area that people are very interested in. HRT is hormone replacement therapy. As I say, it's kind of gone in and out of fashion over the decades, but now the current HRT that we're using is very safe, and it's first line as per NICE guidance. So basically, if you are a woman with the right symptoms at the right age, then you should be offered HRT first line by your doctor or healthcare professional. But it's not just about the HRT, and I think that's really important. It's also very important to focus on lifestyle and diet and exercise. And I know you guys are all keen hockey players, so I know that the exercise box will be ticked. But I'm going to go through that as well, because sometimes you can have too much of a good thing, and it's an interesting life stage, this life stage. And then finally, how do we diagnose it? So for the majority of people, it is a clinical diagnosis. So as I say, the right symptoms at the right time with the right age, you don't actually need a blood test. So when people say to me, or, I've been to my doctor and they said my bloods are normal and I'm not perimenopausal. And it's like, well, if you're sort of mid-40s and you've got symptoms, it doesn't really matter whether your bloods are normal or not, because it's just a snapshot of a roller coaster. So actually you are perimenopausal because you're having symptoms. So bloods don't necessarily rule it out. We do use blood tests for early menopause, for ruling out other things like thyroid, anemia. And we also use blood, say, for example, if a woman has a coil and doesn't have periods and she's keen to know whether she's been through it, they're very useful. And we look at something called the FSH, which is the follicle stimulating hormone. And if it's raised on 2 occasions 6 weeks apart, that's a good sign that you're postmenopausal. But most of the time, the women I see, it's a clinical diagnosis. Okay, so I'm going to talk now about Sam. This is just a case study. And Sam is 45 years old. She is a keen hockey player. She's got a stressful job. She's a mum of 2. And what often happens with women at this life stage, and especially active women, is they have been active their entire life. They know how their body works. They know how to prevent the injuries. They know the exercises they need to do to warm up, to warm down. They know how to keep the weight under control because they've been doing it all their life. And then they get to sort of mid-40s or late 40s, early 50s. And suddenly what they've been doing their whole life just doesn't work anymore. Like suddenly, they feel like their body shape's changing, or they're getting niggles, or they're low in energy, or it's just all the wheels sort of start to come off. And this is what's happening with Sam. So and again, this is sort of something that we see, is that she's feeling like she's getting niggles. She's feeling like she's gaining weight. And so instead of kind of taking a bit of a break and sort of taking a step back and saying, right, what's going on? She's just training harder and harder and trying to kind of push her body more. She's also telling me that she's a bit anxious. She's not sleeping very well. And she's also noticing, and this is something that often doesn't get mentioned, and this is something that we do talk a lot about at the Well HQ. She started noticing her pelvic floor isn't working as well as it used to. So she's got this sensation, this feeling of heaviness, of dragging when she's doing, after a long session, say she's been running or she's been lifting weights, and she's aware of it. And she doesn't like that sensation. And she's thinking, what is going on? And this with Sam, if she came to see me, she is the right age, the right symptoms. She's telling me she's getting these niggling and injuries. She what I would do as well, I'd want to know about other symptoms like hot flushes and night sweats and aches and brain fog and all the other things that go hand in hand. But I would be high level of suspicion for that she is perimenopausal, and that we need to start thinking about management. So it doesn't necessarily have to be HRT, but it certainly could be. And for her, one of the first things I might suggest for her is some vaginal estrogen, which I will go through in a lot more detail. But that will really strengthen her pelvic floor and may really help her. So I've told you about the perimenopause and the fact that it's no longer this sort of regular ovulation. And the thing is that as I mentioned, some people go through it and it's like a year, and some people go through it and it can take a decade. And so, and it's one of those things where the menopause is a lot more common than I think we think it is. So, for example, 1 in 100 women under 40 will go through the menopause, 1 in 1,000 under 30, and 1 in 10,000 under 20. So you think about a large corporation or a large university, there will be a couple of young women who are perimenopausal or having symptoms or experiencing things that they're not sure about, who are vulnerable. And actually, that's why having talks like this, reading books, watching documentaries, many of you may have seen Davina McCall's documentary. It's just so important, because normalizing this conversation and reaching out to these people, it could be life-saving, life-changing. So yeah, it's really, really important. This is quite a scary slide, and I don't mean to scare anybody. And I'm sure many of you, if you've been through the menopause, can see a couple of things there that sort of ring true. The very classic thing that everyone talks about is hot flushes and night sweats. That's kind of like the one that it's sort of almost it's famous for. In my experience as a doctor, I see that the mental health symptoms are often the first things that people tell me about. So it's I'm not an anxious person, but I'm feeling really panicky. I'm not normally an angry person, but I keep getting this red mist. I feel very emotional. I feel really close to tears all the time. I don't feel myself. That's a very classic one. I don't feel myself anymore. And the mental health symptoms often come first. But if you think about our bodies, and you think about the fact that we have estrogen receptors everywhere in our brains, in our heart, in our skin, in our pelvic floor, and your hormones are going up and down, and at times your estrogen levels will drop really low, that can cause all sorts of symptoms. And that can be, some are very much in the perimenopause, and some are more when you're postmenopausal and your sort of hormones flatline. But I saw a lady today who said, I just get such a bad allergies. I never used to have allergies. And I was like, that's probably menopause, because we know that our histamine rises as our hormones change. And so by going on HRT actually may really help manage her allergies. And so by looking through, rather than scaring you, it's more to say that, again, we are all so unique and so different, and everyone will find that they are affected differently. So at this point, I like to do a little kind of FAQ thing, because I'm sure lots of questions are generated. And so, can you be perimenopausal and still have periods? Yes, you can. So you can come to me and say, I've got hot flushes, night sweats, brain fog, poor sleep, aching joints, but my periods are really regular. I'm 45 or whatever your age is. Yes, you can still be perimenopausal. You don't have to not have a period to be perimenopausal. And do you need contraception during the perimenopause? Yes, 100%. And pregnancies do happen, believe it or not. And so up until the age of 55, women should really be having contraception. And that's why some women are on HRT and the pill. Some people are just on the pill. Some women have the Mirena coil. That's why it's so popular at this life stage, because it does both. And it also helps to lighten or stop periods, which can be a godsend, especially, as I mentioned, that your periods can be very unpredictable. They can be extra heavy, and you can get something called a super period, which is when you kind of get like 2 or 3 months build up of endometrium, and then you bleed, and then it's a bit of a flash flood. And the Mirena coil is very good at preventing that. So that's why that's so popular in the midlife. How long does it last for? As I say, it can whiz by, or it can take a decade. Is it all doom and gloom? I get asked this so much, and the answer is no. And the reason I say no is that for girls, you start your periods in your teenage years, and that's the beginning of the fertile years. And for many women, more than we give credit for many women, they have estrogen sensitive conditions like endometriosis, like polycystic ovarian syndrome, like very heavy, very painful periods, premenstrual syndrome, this thing called PMDD, which is premenstrual dysphoric disorder. This is when you feel very low in the few days leading up to your period. And for them, they find the fertile years really hard. And I think the more we're researching women's health and the more we're understanding it, the more the diagnoses are coming, and we're realizing that more women are affected than we thought. And so for these women, when you go through the menopause, it goes quiet. It stops. Those kind of nightmare years of having pain or painful sex or heavy bleeding or whatever, it goes. And so, no, it's not all doom and gloom. It also is a life stage, I think, when women can be a bit more assertive and can actually wipe the slate clean. So rather than just kind of carrying on, they can say, right, how am I going to do this differently? what am I going to do differently? I'm going to put myself first, and I'm going to change this and do this. And that's why I think for some women, it's quite a powerful stage. So we need to rebrand it, and we need to relabel it as something a bit more positive. Do normal bloods exclude the menopause? I think I answered that already. No, you can still be perimenopausal and have normal bloods. Does everyone want to talk about it? You'd think so, because there's been so much kind of chat about it. But no, you get some people that just don't want to. And so, you know, I find that in life you get sort of people that really don't want to talk, and then you get the oversharers that really love to tell you everything, and then you get the people in the middle. So I think just being aware that, well, you know, it's one of those things. Not everyone wants to talk about it. So what is the impact of the menopause? So I see this a lot, but I'm sure that this will ring true to you guys a lot, with friends, with, you know, other people that you've known who've been through it. But it can affect a woman in every way, especially when we didn't know what it was. I think in the last 5-10 years, there's been this massive shift in knowledge and training. I think healthcare professionals are better trained, medical students are better trained. You know, there's now the British Menopause Society. I think that has really helped. And it's everywhere. And so I think people are more comfortable talking about it. But Baz always talks about the fact that her mum was a teacher, and she remembers that she really struggled when she was in her kind of late 40s, and then ended up giving up her job as this amazing teacher. And Baz was like looking back and going, I know that was because of the menopause, and that's such a shame. And we know that 10% of women actually retire from their job because of the menopause, and 20% take time off work because of symptoms. And this is an inevitable female life stage. So that's actually a travesty. And what that then does is it just widens the financial gap, the gender gap, and widens the pension gap and all the other things that happen. It also affects a woman's confidence and can impact her private life, her sex life, her family life. You know, I have patients that say to me, I'm just being so unkind to my family, and I don't know how to control it. I'm sort of shouting at them. And actually, and I say this, you know, it's a really sensitive, difficult thing to say. But the Office of National Statistics does say that actually the midlife for women is when women are most at risk of suicide. And that is because women are vulnerable, because the impact that the perimenopause can have on their mental health, their confidence, their self-esteem, and everything that goes with it is huge. And so again, these women can be vulnerable, and that's why it's just so important that we are talking. Okay, so I've already talked about Sam, and so she's reaching out to me. She wants to talk about kind of what the options are for her. So the first thing to say is HRT. So she could benefit from some estrogen and progesterone, and even maybe testosterone. I can talk in more detail about testosterone if you want me to. But she could benefit from, so the estrogen will help with a lot of her symptoms. The progesterone is to protect her uterus lining from the estrogen. And that could, in the short term, HRT is fantastic because it helps very much with the symptoms very quickly. And you have to titrate. We start low and we work up slow. So you titrate it up very slowly over 3 months, 6 months, following up regularly until you get to a level that you're happy with. And sometimes you kind of start off and you feel amazing, and then it will dip down a bit, and then you have to increase it. But yeah, so HRT also has long-term benefits. So we know that it protects our bones, our skin, our mind, our cardiovascular risk. It can help our bowels, maintain our muscles. So for many women, actually, it's a fantastic thing to offer them. Not everyone wants it, not everyone needs it, and not everyone can have it. And in fact, there's a whole cohort of women who have had, for example, estrogen receptive breast cancer who cannot have HRT. And so I do sometimes feel that you know, when you read social media and you read all these people that are talking about HRT, and it's like, we have to remember that not everyone can have it. And there are alternatives. So there are non-hormonal medications that you can have. So for example, antidepressants and anti-epileptic medications can help with things like hot flushes and night sweats. There's also non-hormonal medications that can help with your mental health. and your bone density and maintaining your bone density. So there's lots of other things that can be discussed if you can't or don't want HRT. There's also things like talking therapies. So CBT there's evidence that it helps with hot flushes and also with some of the mental health symptoms that come with menopause. Exercise, I mean, I don't need to tell you guys how important exercise is, but bone density, so doing strength exercise is so important. And it's important for maintaining muscle. So we start losing muscle and our bone density from our mid-30s onwards. And it's a real challenge to maintain it. And people think, oh, I don't want to bulk up, I don't want to be, but actually, no, you're not. It's just literally trying to maintain it. And so by doing strength exercises and it's just so important. And I will talk in a bit later about stress and cortisol, because I think sometimes women at this life stage, someone like Sam, who is quite time poor, the temptation, I don't know if you would agree with me, but the temptation is to try and do as much, kind of burn as many calories as you can in a session, in a gym session or in a fitness session, because you think, oh, I've only got half an hour, so what I'm going to do is going to do HIIT, and I'm going to do it like 3 times a week, and I'm going to do it as fast as possible. And actually, often when you're time poor, you're pretty stressed, and so then your stress levels just go even higher, and it can have a negative effect. And actually, what we need to be saying is mix it up. Do something, yes, do HIIT, but then do yoga, and then do some cardiovascular, and then do some low intensity, and don't just keep thrashing your body, because you will get injured. And actually, it's a really good time to kind of rethink this. And then the last 2, nutrition. So in terms of, for menopause, making sure you're getting enough of all the important foods, rainbow foods, making sure that your gut bacteria is as healthy as possible, lots of protein, lots of fruit, lots of veg. And then lots of people ask me about supplements. And the thing with supplements is there's never much research or studies that kind of support it, because the studies aren't done because there isn't the sort of the financial kind of incentive often. But some women absolutely swear by them. So there's things like black cohosh, red clover, sage, and I'm sure will heard of loads of others. And my ethos with that is, if you feel it helps and it doesn't cost you the earth and it doesn't do you any harm, then go for it, So there's lots of different things that we can think about for Sam. So HRT in a bit more detail. So estrogen can come in lots of different forms. It can come in a tablet, but actually the recommended way now is what we call transdermal, which means through the skin. And the reason why this is much more popular is because when it goes through the skin as a gel or a patch or a spray, it doesn't go near your liver. It doesn't have to be broken down by your liver. So it doesn't then affect your clotting factors, which means that if you have had if you have a risk of blood clots, or you may have, risk of stroke or other things like that, then the risk is there isn't an additional risk with transdermal. So it suddenly takes that whole thing out the equation. And so transdermal is very much now the norm. So most women will have, as I say, either patches, gels, or sprays. And the patches twice weekly, so you put it on and it stays on. The gels, you pump, it's like you pump it and the same amount comes out each time, and that you put on every day, and you can put it on your thighs or your buttocks or your arms, but I wouldn't put it on your breasts. And then the spray is the same, you just spray it on every day. And as I said, I've already sort of mentioned that the benefits, but there's huge benefits. And the other thing that I mentioned about Sam is her pelvic floor. In fact, I saw somebody today who was like, telling me about their pelvic floor, and I was trying to convince them about the fact that they needed vaginal estrogen. And so I think the statistics are something like 80% of women will be affected by a weak pelvic floor and will need estrogen, and only 10% of women actually get the right treatment that they need. I'm hoping that that's changing, because you can now get vaginal estrogen over the counter. And I think there's, as we start talking more and more, I do hope that women realize how important it is. And I actually think that anyone over the age of 50 should be offered this, because it's that common. And I think people don't realize how so often people think it's just about vaginal dryness, and it's not. It's about recurrent urinary infections. It's about pelvic floor strength. And just by having a vaginal pessary or a tablet or cream twice a week, that can be really like game changing for women. And it's the equivalent, having that dose twice a week is the equivalent of 1 HRT tablet in a whole year. So even women who have had breast cancer, they can still have topical vaginal estrogen and have a much better quality of life. So it's just something to think about. Okay, so that's the first hormone is estrogen, and then the progestogen, as I said earlier, you have to have progestogen if you have a uterus. If you've had your uterus removed, so if you've had a hysterectomy, you don't need the progestogen. It's literally to protect your uterus from the estrogen, and without it, the uterus lining can get thicker and thicker and thicker and thicker, and could develop into endometrial cancer, which is cancer of the lining of the uterus. So it is really, really important. And that comes in the form of a tablet. So you may have heard of Utrogestan, which is a micronized progestogen, and it's very popular because it's so similar to the hormone that we have in our own body that there's very few side effects. It's really well tolerated. In fact, it's really handy because it helps you sleep. Progestogen is a very calming, relaxing hormone. And so if you take it in the evening, it can be really, really nice. Or you can have it in the patch, which is a synthetic progestogen, or you can have it in the coil, as I mentioned earlier. And then there's testosterone. And testosterone is, it's a bit of a tricky one. I did a talk yesterday and someone was asking me about it. It's not licensed in this country at the moment, which is why it's a real pain, because it's licensed in Australia, which I just think is, I mean, of course, the Aussies have got it sorted, of course. But yeah, it's not licensed here. So anything that's prescribed, I basically have to prescribe a male sachet to a woman. And at the moment, it's like have a 1/10 of a sachet every day, which is ridiculous. It's like, imagine like one of those tomato ketchup sachets and saying, right, you can only have a 1/10 of a sachet on your chips every day. You'd be like, what? And I don't know that there's any move to license it or to change how it's produced into what sizes, and whether there's a kind of a more female friendly version, which is slightly annoying. And because it's not licensed, it means that not every doctor is able to prescribe it, because you can only prescribe it if you have the expertise to prescribe it, if that makes sense. So therefore, there's this kind of a slight testosterone lottery, depending on what your surgery, what your doctors or whoever you see can prescribe. The other thing that's quite interesting was I went on the Telegraph podcast with Laura Kenny, and we were talking about athletes and the fact that it's for men, they can take testosterone and it's allowed if they're competing at a higher level event, but for women it's not allowed. And so things I think have got to change, because women now, as I said, they can go through surgical menopause in their 20s, and that would be still classed as a deficiency, and therefore they would need it. So I think there's a long way to go in terms of supporting women, especially athletes, with hormones, and testosterone is, definitely something that needs looking at. Right. And so the other thing I was going to mention about HRT, so it has all these benefits, the short ones, which are symptom control, the long-term ones, which are helping your bones, etc. There are a few risks, and I've mentioned the uterus lining risk, but the other risk to mention is the breast cancer risk. Now, I don't know how well you can see this slide. It's the women's health concern. It's a fantastic slide, because basically, it's if you look at it, it's so 23 cases, or in 1,000 women, there'll be 23 between the ages of 50 and 59 who develop breast cancer, and that's kind of like the standard. If you look at the next one down, if you put somebody on HRT, then 4 more cases of those 23. So instead of 23, it'd be 27 in 1,000 will be diagnosed with breast cancer. And then if you go down 2 more, that's the same as being on the pill. And if you go down another one, then there's actually one more, so 5 more cases, 28 cases, if you drink more than 2 units of alcohol per day. And then if you go right to the bottom, one up from the bottom, if you're overweight or obese, it's 24 more cases. So it's more risky being overweight or obese than it is to be on HRT by far. And then right at the bottom, if that's exercise, so if you're 7 fewer cases in women who get breast cancer if you exercise for 2 hours, 2.5 hours per week. And I was just saying to this lady today, like, if I give you HRT, she will get the energy, because at the moment she's feeling so ghastly, she'll get the energy to then exercise again. So it's kind of like a lifestyle thing. It's like, you know, if you don't feel so ill, you might drink less wine and you might exercise more, and therefore your risk goes. So it's kind of like understanding the risk profile. However, if you have like a really strong family history of breast cancer, obviously you really do have to take this into account. But it is something to think about. Okay, at this point we have more questions. And I think I've kind of answered. Does everyone need it? No. Your body will tell you, like, not everyone wants it, not everyone needs it, not everyone can have it. And I think with all kind of revolutions, the pendulum can sometimes go too far to start with, and then it will come back. And I've sort of had, you know, kind of 35-year-old women coming into me and going, I think I'm menopausal, I think I need HRT. And it's like, whoa, hang on a minute. You know, let's talk this through, because you might, but you know, it's very unlikely, you know. And so I think your body will tell you when you are needing HRT. So, you know, again, the right age with the right, and that's the other thing. People say to me, well, if I don't take it, shall I just go on it even though I haven't got any symptoms? And it's like, no, don't just go on it, because there's no indication for it. It's not needed, if that makes sense. Can I be too old for HRT? So they talk about the window of opportunity. So for most women, the advice really is to start the HRT within 10 years of your last period. And this was what, so the studies that were done about 25 years ago, the Million Women study and the WHI study, those are the studies that really sort of kind of scared the whole world about HRT. The flaws that they found in those studies was that HRT wasn't being given to women who were perimenopausal. It was being given to women who were 10, 15, 20 years post-menopausal. And it makes sense. And when you've had sort of 10, 15, 20 years of no estrogen, to then suddenly give someone replacement estrogen, it was causing heart disease and strokes. Whereas if you get in sooner and you give the woman the estrogen whilst she's perimenopausal, so she doesn't actually lose what she's already got, that is the safest time to do it. So yes, in theory, you can be too old for it. And that has to be discussed with your sort of the doctor or healthcare professional who started it. But generally, it's about 10 years after your last period is the cutoff. And how long can you stay on it for? Well, if every year you should have a review, and I see all my patients for a review, as long as the benefits outweigh the risks, then you can stay on it. And a lot of women get to about sort of 60, 65 and go, oh, I'm done. You know, I just don't want anymore. I just want to go back. And then they come off it. But some women, I have women in their 90s and they're 95 and they're like, nah, that's it. I'm never coming off it. And that's, as long as the benefits outweigh the risks, then happy days. And then this is a really common question. Does HRT just delay the inevitable symptoms of menopause? No. And the reason that's the case is that it gets rid of the symptoms now. And then when the time comes that you want to come off it, you come off it in a very controlled way. You gently bring it down. And then when you've stopped it, the symptoms have gone. And you know, the majority of women then actually don't need anything. So it doesn't delay. It just gets you through the kind of the hormonal roller coaster. So going back to Sam, she, as I say, so she's somebody who is perimenopausal. She needs a good chat about her lifestyle, her stress levels. We start her on HRT. She's deciding to do less of the she's going to mix up her exercise a bit more. She's not going to be flogging herself too much, and she's going to look at her stress management. And that is what I want to just focus on a little bit before we finish. So why stress management? So this is a fantastic quote by Brené Brown, who I'm sure you've all heard of. She's an American writer. It takes courage to say yes to rest and play in a culture where exhaustion is seen as a status symbol. And I just love this, because I think certainly as a GP, you know, anyone in the NHS, it's crazy busy. And when we take any time off, generally it means that somebody else has to sort of pick up the pieces or cover you, you know. In any job like that, it's hard to take time off. And I think we have to realize that rest is a superpower, and that we do have to prioritize rest, especially at this life stage. And that is partly because this life stage, the midlife, is societally it is really stressful, and physiologically it is really stressful, because the hormones are going through such a change. So rest is our superpower. So how does stress affect our hormones? So cortisol is made from cholesterol, and so are our sex hormones. So estrogen, progesterone, and testosterone are all made from cholesterol. And if cortisol is high, it competes and it pushes down our sex hormones. So that can affect the regulation of our periods, whether we ovulate, and therefore our fertility. It can heighten and exacerbate and exaggerate menopausal symptoms, and it can reduce our testosterone, so reduce our libido. So stress can directly affect our hormones. And we actually saw this anecdotally in lockdown, where women were pushed into that. I mean, I don't know if you remember where you were, but that awful pressure pot of childcare by day, work by night, not having any of the self-care that we did, that that you rely on, like the gym or going to the hockey or going to training or even having a facial or meeting a friend for a coffee. Like, all of the self-care had gone, and women were noticing that their periods were heavier, irregular, that they were getting menopausal symptoms, and then when the lockdown was released, those symptoms improved and their periods went back to normal. So it was a really interesting sort of anecdotal experiment, I suppose, in a way. So how do you downregulate stress, and why? So what we want to do with stress is, a little bit of stress is actually really good for us, you know. So an ice bath is a way of putting your body under stress. But when you do an ice bath, you prepare, you hydrate, you fuel, you do it together, probably with a buddy. It's all under control. You have a period of time when you're in the cold, then you get out, and then you reflect, you fuel again, you hydrate, and you know, everything is done very controlled. And that is the stressful event is you can absolutely see it, and then it's surrounded by no stress. And the problem with our lives now is that there's just chronic stress of sort of micro stresses all the time, emails and social media, etc., etc. And so what we need to do is find ways of lowering our cortisol, lowering our adrenaline, lowering our blood pressure, slowing down our heart rate. And you know, I'm sure you know most of these things, but things like, I say this to so many people, boundaries is the first thing, because if you can really instill your boundaries and say, no, this is my time, you are not coming into this time. And I think for women, that's in midlife especially, it's quite hard, because often you're caring for your kids, for your parents, you've got a job, you know, there's so much going on. So making your boundaries rigid and keeping to that. And relaxation. So, you know, breathing exercises. I had this fantastic osteopath, and I was going through quite a stressful time. And she said to me every night, she says, lie in bed with a straw. And she said, imagine you're a lilo deflating in your bed, you know, just slowly going, someone's taken the plug out, and breathe out of the straw and slowly allow your body to deflate. And she said, do that about 5 times. And I found it so amazing. But it doesn't matter sort of how you do it. It's just finding a way that helps you. Exercise, I think I've sort of already alluded to this, but Sam shouldn't be flogging herself all the time. She needs to mix it up, and she needs to be kind to herself, and have, you know, maybe there's a bit, I mean, we talk about at the Well, we talk about the fact that every woman in a sort of a HIIT class or something, you should have 15 minutes at the end that you should just allow us to lie on our mat and just breathe, because actually no one would be ungrateful for that. We'd all be grateful for that time to just lie still. And also social support. So never underestimate the power of community. You know, you guys all together, the team, the thing that was taken away in COVID, we realized then how much we need it. And when we talk, we release cortisol in our breath, in our tears. Even when we journal, we release cortisol through writing about our problems. And so however you do it, it's just really important to share. It's important to sleep well and focus on lifestyle. So what I mean by that is making sure that you switch off social media, make sure you don't have too much of these micro stresses. So being on these WhatsApp groups, you know, that just keep coming notification after notification. I've mentioned CBT already. Again, it's really good. And then medication. So I kind of wanted to highlight here that I think it's really important that we look out for each other. And there does come a point where, you know, someone might actually need to go and see a specialist, or go and see a doctor, or go and see a healthcare professional. You can try all these lifestyle things, but actually sometimes they do need medication or whatever. And that's really important to signpost them. And then other things to downregulate stress: creativity, singing, drawing, painting, like it, you know, however you can manage to get your stress down. Right. I've got to the end. Wow. So my 5 take-home messages for menopause. It is an inevitable female life stage. It is very individual. So every menopause journey is different. And therefore every management is different. It's a clinical diagnosis, so you don't need a blood test, but I'm really happy to answer any questions about that if you'd like me to. And there's so many treatment options available now for women. And I'm actually quite excited that, you know, we're hoping that there's going to be more research, more understanding. You know, watch this space about testosterone. That would be incredible if it was available for women. But it's also lifestyle. Lifestyle is so important, managing our symptoms and also managing our stress. And I think I'm going to stop sharing.